Well, welcome everybody. So we've got 61 people here now. So it's 1 minute past 7. So we just had some minor technical hiccups. Hopefully that's an end to our hiccups for the evening. Famous last words, shouldn't curse us, should I? So it's lovely to have you all here on this day where we have actual sunshine. We've had actual sunshine here, actually all actual day. Amazing. So I would like to introduce myself. My name's Linny. I work for Parkinson's UK as newly diagnosed development officer. I'm going to introduce the panel in a few moments. I wanted to remind everyone that this webinar will be recorded. You won't be able to see any of the audience on the recording. It'll just be the panel who will be showed. We did have quite a few questions sent to us in advance. And we will hope to do our best to answer those. We're not probably going to get through all of them, so apologies in advance for that. We will have the chat function open. I can see some of you are using it already, so do feel free to pop questions and comments and things like that in there, and we'll do our best to pick those up as well. After the webinar, we'll share the recording with everybody, and we'll also share some follow-up kind of signposting and things like that with you, along with some evaluation and an opportunity for you to feed back to us. We are lucky enough to have 2 clinicians with us tonight. But just to remind everybody that they will be here, they'll be able to give sort of general information about medications and tips and things like that, but they're not going to be able to do any sort of individual advice or consultation because that wouldn't really be appropriate. So I'm going to call you one by one, panelists, if that's okay, and get you to just introduce yourselves and say a little bit. So can I start with you, Sandy?
Yeah, hi, thanks, Linny. Hello, everyone. My name's Sandy and I work on the National Helpline for Parkinson's UK. So we take calls from all over the UK, wherever you are, and we answer questions on absolutely anything to do with Parkinson's. And sometimes it has to be said, the link is very tenuous, but that's fine. You know, we can normally signpost well if it doesn't sit with our team. So yeah, that's me.
Thank you, fabulous. And Maureen, can I come to you?
Yes, I'm Maureen. I'm from Belfast. I don't work for Parkinson's. I live with my husband, who has been diagnosed now for 11 years. So we live with Parkinson's on a daily basis.
Fabulous, thank you. And Camille, can I come to you?
Thank you. Yeah, hello, everybody. My name's Camille Carroll. I'm an academic neurologist and I'm based at Newcastle University, and I've been there for the last year. And prior to that, I was in Plymouth Hospitals and Plymouth University. And my specialist interest is Parkinson's, of course, and I am very interested in developing care pathways to helping people manage Parkinson's for themselves and understand how it affects them. And my other main research interest is in trials. So I run a series of trials in Parkinson's, and particularly trials of agents that might slow or stop Parkinson's progression. So it's lovely to meet you all here this evening.
Thanks, Camille. And Simon?
Hi, everyone. I'm Simon. I was diagnosed with Parkinson's when I was 45, which was 7.5 years ago. I've been living with the condition for some time, and also an employee of Parkinson's UK.
Fantastic. And last but definitely not least, Kelly.
Hi, I'm Kelly. I'm one of the Parkinson's clinical specialist nurses who work in Newcastle. I'm one of the lead nurses and I deal with all complex therapies such as duodopa and apomorphine, and I leave the DBS to the clever people. So yeah, I look after an array of Parkinson's patients.
Fabulous, thank you. So we'll get launched straight in. So one of the questions that we were asked was how often should a person with Parkinson's be seen by the consultant or specialist nurse team? So before I hand over to anybody else on this, I just wanted to say that there are nice guidelines covering England. It doesn't cover the nations as well, but usually they will adopt those NICE guidelines. And what they say is review the diagnosis of Parkinson's regularly. Consider if there's any atypical features, and people diagnosed with Parkinson's should be seen at regular intervals of roughly 6 to 12 months to review their diagnosis. And I just wondered if Simon, if you wanted to come in and see if that's your experience, and maybe then Maureen.
Yeah, sure. So my experience is I see my neurologist once every 12 months and my nurse once every 12 months as well. But they sort of time them so that I see one of them every 6 months. So I typically see my neurologist in October, November time, and my nurse in May or June time. But again, the nurse is also very, very accessible, so I can see it in between times if I need to.
Perfect. So that works pretty much well according to what those guidelines say. And is that your experience as well, Maureen?
No, unfortunately not in Northern Ireland. And I don't want to be negative, but Patrick hasn't seen a Parkinson's nurse in 11 years. Now, we were fortunate in that he had private healthcare. So his diagnosis and his treatment up until last year was once every 3 months private. But the consultant advised him to stop going private because he wasn't eligible then to attain things from the NHS like physio and different things. So his last appointment was last June, and we're still waiting on an appointment. So I don't like the fact that he had to stop going private, because over here in Northern Ireland, unfortunately, neurology is one of the departments with the longest waiting list. So no, it's not good here at the minute.
Thanks, Maureen. So it does depend a little bit where you are. What about you, Kelly or Camille?
So I work within a service where we generally see the patients every 6 months. Some of our neurologists probably see them every year to 18 months, but we fill in the gaps. And we also have regular follow-ups from a telephone point of view. So sometimes we can speak to people on the phone and solve those problems, so they don't necessarily have to come in to see us. And if people were having problems, we might review them, at a 6-week period on the telephone. So we'll be quite accessible, probably in Newcastle.
And what should people do if they have a concern, Kelly? So it's not due; they're not due for an appointment.
We have a telephone service where the patients or their carers can ring into our secretaries. And the secretaries, we give them a little crib sheet and they understand a little bit about Parkinson's, so they know which things to pick up on. And then if it's anything urgent, we have a Parkinson's email box, which the secretaries can email into, or any doctors or GPs. And we pick up from there and we sort of triage that from some of the words. And some of our patients we know really, really well. So more of our complex patients, we will probably ring straight away if there's any problems. But we do have 3 or 4 telephone clinics a week that they have access to if they need it. And some people don't get rang straight away. Sometimes it might be a week till we ring them. So it all depends on that initial, what that patient or carer says on the telephone.
Yeah. Anything from you, Camille, before we move to the next question?
Yeah, I'll just comment on that and also pick up on the question that Jed has put in the chat, because it sort of pertains to what I was going to say, which is that I agree that there is a need for frequent review, or at least regular review, I would say, every 6 months to 12 months within the first 2, 3, 4 years for diagnostic purposes, just to make sure the diagnosis is correct. There are other conditions which can look like Parkinson's, and there's no way of differentiating often in the early stages. So that is important to bear in mind. And if you have a diagnosis of Parkinson's and you think that your Parkinson's isn't like other people that you know with Parkinson's and you're concerned, then please do reach out to the clinical care team, because that certainly is not an uncommon circumstance that we revise a diagnosis. In terms of how often people should be seen, I mean, there are two reasons to see people, really, just in sort of simple terms. One is to check how they are and to look for signs of progression, or that the Parkinson's is affecting them in ways that they might not have been alert to, and that allows you to treat complications as they arise or prevent complications from getting worse, that sort of thing. And so a regular review system is useful. The other reason to see people is exactly what Jed put in his question, that somebody might be developing a new symptom. might be related to Parkinson's, might not be, but it's certainly worth flagging that, because if it is new, then almost by definition it's got worse because it wasn't there before and it's there now, and we don't know whether it's going to continue to get worse or whether it needs a new treatment or a change in treatment or some sort of self-management approach to prevent it from getting worse or reducing its impact. So if there's anything concerning, then absolutely flag it to your clinical care team. And as Kelly said, these days we're so fortunate that we've got lots of different ways of reaching out to people, whether it's by email or telephone or video consult or a physical trip to clinic if that's what's needed. But there are so many different ways of getting help, and I'm sure Sandy has provided a lot of help just using the hotline that Parkinson's UK provides. So don't sit with new symptoms, particularly if they're bothersome to you.
Thank you. Yeah, so big message there to definitely get in touch. Somebody also asked a question about the ratio of NHS Parkinson's staff to patient care per population. So how many patients should, for example, Kelly expect to have on her list? And we looked around for the answer to this, and there's actually at the moment, there's no official statutory or government guidance on those ratios. However, Parkinson's UK and others have done research, and we feel that the average caseload for a Parkinson's nurse should be somewhere around 300 per full-time post. But if it's in a rural setting, a little bit less than that too. However, you know, as Maureen has said, and Kelly might comment, I don't know how realistic that is.
I think we have a lot more than that. So yeah, we there's only one full-time member in our Parkinson's team. We're all part-time. So, and I think at our last count, we were probably about 1,800 to 2,000 patients, I think. So yeah, we're definitely over what we should be.
Yeah, and just to say, you know, at Parkinson's UK, we do quite a lot of other work around campaigning, around research with our excellence network as well. So we are trying to improve those things and raising issues with government around resources for NHS and things like that. So next question is about medication and timing, and especially around meal times. So I don't know who would be willing to start with that. Maybe Simon, would you be willing to talk about that?
Happy to, yeah, very happy to. So I take Cinemet 4 times a day. I take it at 7, 11, 3 and 7 is my routine. I was told nothing about taking medication in and out of meal times when I was diagnosed and prescribed. So I've learned by reading and talking to other people about trying to have like an hour either side of a meal to take medication. And I certainly see a bigger impact from the Cinemet when I do take it on an empty stomach, as opposed to if I take it after a meal, and when I have to. So no clear guidance given when I was diagnosed or prescribed, but I've learned it as I've gone along. And I do find that having an hour or even half an hour between medication and meal times does help me.
Interesting. Kelly, anything from you on that?
We always give guidance that it should be taken as on an empty stomach, as it works better in less protein. Sometimes it helps the absorption. However, some people go, I don't remember to take it on an empty belly. I just take it with my breakfast or with my lunch or with my evening meal. So I think it very much has to be tailored to what people remember as well. And some people feel sometimes a little bit sickly. So I always say take it with a little bit of a biscuit or a cracker might help. And then hopefully the sickly, nauseous feelings might disappear later on. But I think for some people, they remember to take it at breakfast time, lunchtime and tea time. So you can, give people support about times. And for me, and it makes, I know this is more for me, but if people have certain times they take them, it makes it easier for me to make a plan around what symptoms they describe to me. So I think, yeah, times are really important.
Maureen, anything for you around that?
Times, again, very important. Setting an alarm, because it can be you get up in the morning, it can be easy to remember that one. But if you're working during the day and you're at a meeting or something, then you realise maybe you forget to take your medication. So having a sort of structured personal plan for you by setting an alarm on your phone or carrying your wee pill box with you, so you can tell by looking you haven't taken your medication and when you have to take it. For us, we had a personal last year. Patrick had to go into hospital, and he had surgery. Now, whilst the staff knew sort of maybe basics about Parkinson's, they had no idea about his medication and his condition, but they were very good. They listened to me about what time he had to get his medication and what he had to get and how important it was. So they actually let me sit with him at night until he gets patches on before he goes to bed. So he wasn't able to do that himself. But I always carry a note as well. I have a list of medication and things like that, because if somebody says to you, oh, what medication is he on? You can't remember. So the old list is good. But yes, alarms on phones are the great thing at the minute.
Yeah.
Can I just add something to that? Because
Yeah.
there's a new app out called Parkinson's On that you can download from the App Store, and that helps you set reminders for your medication. And I use that personally. It makes a little rattling sound when it's time to take your medication. It's really, really helpful. So if anyone's listening wants to download it, it's on the App Store, and you can download Parkinson's On. I personally find it very, very, very helpful.
Parkinson's On. Yeah. Top tip there. And somebody's asked in the chat, in the Q&A there, how do I find a Parkinson's nurse? Does anybody want to go through that?
Yeah, I can answer that one. Yeah, and we're finding, just to sort of backtrack a little bit, but on the helpline, I think we've seen a real uptake of people wanting to look in the private sector to even get a diagnosis. We must take a handful of calls every day about, I've been told I've got to wait a year, 8 months, 6 months, something like that, before I can even sit in front of a specialist for a diagnosis. So people are looking to the private sector now, which is absolutely fine, and of course their prerogative. The only thing is, Parkinson's nurses work within the NHS. So if people do have a private diagnosis, they won't automatically be referred necessarily to a Parkinson's nurse. So the way it generally works, when you're diagnosed, the specialist that diagnoses you in the NHS would make a referral to a Parkinson's nurse service. There's lots of them all over the country. Some areas haven't got, or they've got one maybe that works part-time and has to cover quite a large area, but that's another subject. But generally speaking, you get a referral from the specialist that diagnosed you to the Parkinson's nurse team, and then the Parkinson's nurse within that team would make contact. In my experience, it can take a couple of months sometimes for them to make that initial contact. But that's how you'd access the Parkinson's nurse service. I don't know whether Kelly's got a different experience or it works differently in your area.
I think it works differently wherever you go. In Newcastle, we're pretty good. If you're there is an array of neurologists. You might go to the movement disorder service and see neurologists there, and they automatically refer you straight to the Parkinson's nurse as soon as you're diagnosed. We follow that up with a phone call after 2 to 3 weeks. And we ask a series of questions, and then we book all the face-to-face appointments. But some neurologists still don't know that we're there. There might not be a Parkinson's neurologist. They might be motor neuro neurologist or MS. So sometimes they keep them to themselves. So I always say to patients who, who I've never met before, oh, how come I've not seen you for a couple of years? And they said, oh, they didn't refer. So if you do get diagnosed, I would say, is there a Parkinson's nurse related to the service? I don't know what your service is like, Camille, but that's how we are.
No, you're absolutely right. I mean, awareness varies, doesn't it, amongst individuals? And if you've been diagnosed by a general neurologist or somebody who isn't a Parkinson's specialist, then the chances are they don't have the same working relationship with the Parkinson's nurse team, or, as Kelly said, even know of their existence. So certainly ask, but if you forget to ask and then your appointment isn't for another year and you're not sure what to do, the other way potentially to access, at least it works in the Southwest, is to ask your GP to refer you to the Parkinson's nurse team, because the community Parkinson's nurses at least in my experience, often forge very strong relationships with the GPs within their patch, and often there's a very good close working relationship there, supporting patients, particularly if there are difficulties with accessing the specialty clinics. And the GPs can refer to a Parkinson's nurse service, and on the whole, Parkinson's nurse services will be happy to accept those referrals as long as there is a clear letter stating the diagnosis. So if the GP is able to copy the letter from whichever neurologist that says the diagnosis is Parkinson's disease, and if you're within that nurse's patch, then that should be another way in. I just wanted to comment on the number of neurologists, because I understand that people do have difficulties, and Pauline has put in the Q&A about the lack of neurologists, and this is something else that I know that Parkinson's UK is lobbying on, so it's why I wanted to raise it, that the UK, I think, has got the lowest number of neurologists per capita, 45 out of 46 European countries or something, so that we are very low on neurology availability, and I'm sure that this is in part resulting in some of the experiences that people are experiencing in relation to seeing neurology.
Yeah, thanks, Camille. I see there's something in the Q&A about medication, and that was one of the questions that one of the themes that came up in advance as well. So I wonder if we could jump to that a little bit. So it's partly around medication. Does everybody with Parkinson's have to go on medication? Also, that aspect of some people want to know, should I start medication straight away, or should I go for as long as I can without medication? And then somebody mentioned something about nausea, I think, with levodopa. So I don't know, Kelly, sorry if I put too many questions to you all at once there.
So when I give some advice on starting levodopa, Sinemet or Madapar, some of you might call it cobeneldopa, some might call it cocareldopa, and I always start with, yes, it can make you feel nauseous when you first start it. That's why I say to take it with a little bit of a biscuit. And if you don't get on with it in I would say give it a good trial for the first couple of weeks. And if you still don't feel very well, I tend to just try the other side. So if you were on Sinemet and you still felt terrible over a few weeks and really didn't want to carry on, I would change it to Madapar. And I always give the choice. And it's the same with, some people are better with tablets and some people are better with capsules. So I always give that patient choice, how are you with tablets, and can you get them out of the packets where the capsules are all in a bottle? So I think choice is a big thing. But yes, it can make you feel nauseous in the beginning. It really can. And sometimes that can carry on as well. If you were to develop diarrhea, then I would definitely swap you either to Madapar or Sinemet. But it's important and I always say when people start taking these medicines is keep a little diary. Because you forget, you come to clinic and you've got that 20-minute slot or on the phone to talk to somebody, keep a little diary, definitely.
Mm-hmm. Simon, have you got any reflections on taking medication and when you started and why and things like that?
So I've been very fortunate not had any side effects. So that's one thing to say. I guess I started off on Rizagiline when I was first diagnosed, trying to delay going on to the levodopa medications for as long as possible. Went on to a small dose of Sinemet after about 2 or 3 years, and then had it increased about 2 or 3 years after that. And if I'm honest, I think I should probably have increased it before I did. Engage in doing that sooner, because I felt so much better once I increased the dosage to a more appropriate level. So I guess my personal experience would be embrace the medication because it helps you with the physical symptoms, also your mental symptoms. So that's my experience personally.
Yeah, great. Thanks. Maureen, anything from you on medication?
The big thing is taking medication on time. Otherwise, the symptoms just go all over the place if you don't be rigid with your medication. I know in our house, Patrick he's increased his patches at night, but he is held off increasing his medication. But I think for him, that's because he has been very fortunate. Before he got Parkinson's, he was an athlete and still is an athlete. So exercise is a major part of his life, and more so now, to ward off a lot of the symptoms. So he is using that to hold back on the medication.
Interesting, yeah. So we do know that physical activity is really, really important for people with Parkinson's, for well-being, both physical and mental health, which leads me on to something else that somebody had raised around mental health, talking about depression and anxiety, and that was an initial symptom before motor symptoms, and asking a question about will that go away? Does it go away with time? And will that worry kind of lift, an anxiety about, I don't know, the future, as well as kind of those mental health issues? And I didn't know, Sandy, if you would have a little tackle of that.
Yeah, oh, absolutely. Depression, anxiety, those are very we get a lot of calls, a lot of inquiries about those emotions, because if people have got a tremor and they've got the motor symptoms of the condition, it's another thing to have these sort of hidden effects as well. They're utterly miserable, and coping with the diagnosis and all that comes with that. So I always try to find out a little bit more about the cause of someone's depression and anxiety if they call the helpline for that purpose. So asking things like, were these emotions happening because you suspected that you might have something like Parkinson's? Have you felt depressed for a long time before? If none of those things really apply, then I know some research has been done that suggests a lack of dopamine, which causes the symptoms of Parkinson's, can be a trigger for depression and anxiety, worry, those sorts of things. And we do speak to people that say that depression happened to them long before, many, many months before they noticed any motor symptoms, as they're called, tremor, rigidity, those sorts of things. Sometimes depression can also be part of what's called non-motor fluctuations. And that's linked to the effect of medication called levodopa, as we've talked about, which is the name used to describe one of the main types of Parkinson's drugs, when it actually wears off before the next dose is due. And if depression, anxiety is caused by that, then it usually gets better after the next dose of levodopa starts working. But there are things that can help. You don't have to put up with this. We've mentioned exercise. That's so good for lots of reasons. We all know that, building physical activity into our day can really be good for our overall health, but it's particularly important for people with Parkinson's. So things like exercise, physical activity, the self-help computer programs that are out there, very easy to find. Therapies such as counselling, cognitive behavioural therapy can be a big help too. Support groups, we've got lots of them all over the UK. Medication, that's certainly available. I think people tend to think along those lines if they feel depressed or anxious. Sometimes medication used in conjunction with the other things I've mentioned can be really helpful. And we've got lots of info on our website about this as well, real life stories as well, because it, as I say, it can be an utterly miserable thing to live with, but you really don't have to. There's lots that can help.
Thanks. And I wanted to bring Camille in there as well. So Camille, we've got a question about, sorry, just looking for it. What medication decisions can only be made by a neurologist versus a Parkinson's nurse? And I don't know if there's anything else you wanted to add to what Sandy said there as well.
No, I think Sandy's answer was excellent, very comprehensive.
Thank you.
I mean, it's exactly as Sandy said, those what we call non-motor symptoms, things that aren't movement related, there are so many of them. The movement related symptoms, as we know, are just sort of the tip of the iceberg of the way that Parkinson's affects people. And a lot of those non-movement related symptoms, of which mood disturbance, low mood or anxiety are examples, can be dopa responsive. So they respond well to dopamine replacement. And there are certainly people who are experiencing those fluctuations of dopamine levels, so the movement can be almost normal and then become very slow and stiff as the dopamine levels fall. And in that sort of off state, when the dopamine levels are lower, people then are troubled by anxiety, which gets better when the dopamine levels rise. Sometimes mood disturbance is related to other transmitter systems being affected in the brain. Parkinson's doesn't just affect dopamine, of course, it affects lots of other nerve cells and different sorts of transmitter systems, serotonin, noradrenaline, acetylcholine, and we need these transmitters to do other things for us, like keep our mood buoyant, keep a lid on anxiety, help us with thinking and memory, those sorts of things. So sometimes we do need to support those other transmitter systems with other medications, which would be the ones that GPs and we would prescribe for mood, whether it's for anxiety or low mood. And that probably brings me to answer the question around what would be within the prescribing remit of a Parkinson's nurse versus a neurologist, and you could almost add into that equation a GP. So, because there are certainly things that I think people should be on, but are slightly outside my comfort zone for prescribing. So generally speaking, not all Parkinson's nurses prescribe, of course, but for those who have done their prescribing qualification, their sort of scope of practice will determine what they can prescribe. And so generally that will be, you know, all manner of dopamine replacement therapies on the whole, plus maybe some supportive therapies, and certainly things for bowels, various types of laxative products and so on. If people have got problems with the bladder, I'm not so sure. I'm looking at Kelly's to see if she nods or shakes her head now. Things like prescribing myrbetriq to help with the bladder, but might be within scope for some nurses, but maybe not for others, for whom they just don't feel comfortable prescribing that. And the same with antidepressants. There are different classes of antidepressant, and selecting them might be a choice that a Parkinson's nurse is happy to make, or a neurologist is happy to make, or maybe neither, and it gets battered to the GP to decide which antidepressant would be better for a particular patient. And the same for bone protection. Actually, we like people. We'd like to make sure that people with Parkinson's have got protected bones in terms of in case they take a tumble. And of course, all of our bones are getting thinner as we get older, so we're all at risk of fractures. And for people with Parkinson's, their risk of fracture is higher. So we absolutely need to make sure we're protecting the bones as much as possible. And there are simple things that I'm very happy to prescribe, like calcium and vitamin D and so on. But when it gets into different classes of bisphosphonates, which is a sort of slightly more the next level up of bone protection drug, I would seek the advice of GP colleagues for that. So it really depends. That's a sort of long-winded answer. It depends on one's own comfort level, what you're trained to do, what you feel competent to do, and if you think as a professional now, if I think that somebody might need some medication that I'm not comfortable making the decision, I would then make sure that I referred that decision to somebody else who was able to make it.
Thanks, Camille. And just sticking with medication just for a moment, because there's a lot of medication questions coming up in the Q&A there. Is there an alternative to Razagiline if it's not available? Kelly, I don't know if you have any thoughts on that.
There is a shortage of Razagiline, actually. We've had a few problems. So we've had patients recently that have had to come off Razagiline because there was no stock of it. If someone's been on Razagiline, they could try sulfonamide, but sulfonamide's a second treatment. You'd have to try Razagiline first. So I always say to a patient when they ring and say, I can't get a prescription, I say, try and ring around to the pharmacies. And also, it comes in brands as well. So some people might be able to get the Azilect brand, and some people might get the generic version of Razagiline. But yeah, there has been a shortage of Razagiline, but we don't have any influence on whether that's going to come back into. But there are other MOAB medications that we do use.
There is selegiline as well. So I don't have a lot of patients on selegiline, but I haven't heard the same shortage stories about selegiline. So I'm guessing maybe there's less demand and there's more of it still in boots. I don't know.
I think it was a selegiline shortage. Then everyone went on Razagiline. Then there became a Razagiline shortage. Back to selegiline.
Do you want to come in on that, Sandy?
Yeah, that's absolutely, Kelly, something that we've taken lots of calls about on our helpline. We've got a good section of our website actually lists medication shortages and when manufacturers have told us that they're likely to get supplies in again. So it's worth having a look at our website if you're worried about medication shortages. And you're right, Kelly, people have said that they're on a particular type of drug, quite happily taking it, but then because there's a shortage of another drug, they're switched to go onto the drug that a particular person's taking, which causes that to be in demand and short supply as well. It's not ideal. It's very worrying for people. I think that's what prompts them to call our helpline, really. But our website's a good source of info. You know, we've got our finger on the pulse with that. And just to mention as well, I don't know whether other pharmacies have it, but Boots have a prescription medicine checker that you can, medication checker. If you go onto their website and put words to that effect into the search option, it allows you to type in the medicine that you're looking for, and I think it probably asks for a postcode or something or an area of the country that you're in. So if all else fails, you could look at that. As I say, other pharmacies might have that, I don't know, but Boots definitely do.
Thanks, Sandy. And again, the medication and shortages is something that we monitor at Parkinson's UK all the time, and our campaigns team do take actions and lobbying government to try to make sure that these things are done better, let's say. Yeah. I want to just move away from medication just for a moment, because somebody sent something in about sort of acceptance of a Parkinson's diagnosis, and this is a person, a family member of somebody who's been diagnosed with Parkinson's, who's concerned that that person's kind of not responded well or isn't doing anything about it. And I just wondered if, Maureen, if you had any sort of insight on that sort of thing, and then maybe come to Simon.
I have to say, when we got our diagnosis, Parkinson's UK were fantastic. They sent a member of the team out to our house, who spoke to Patrick and I, addressed a lot of our queries, and then afterwards spoke to our kids, because the kids were relatively young as well. So right away they were straight in there, helping us adapt. Now, I have to say, and I know it's not the norm, my husband has always been a very positive person. And yes, he was knocked off his feet, but he still continues to be that positive person. Parkinson's have always been there for us with any questions that we've had. We find a lot of help in the support groups, the cafes, meeting up with people, building new relationships, and realizing you're not out there on your own. Especially for the younger people as well, who are trying to hold down a job, raise their family, things like that. Get out there, get shared stories, get support, forge relationships and links, and help each other. Because especially in this day and age, when the NHS isn't what it should be and could be, we need to help each other.
Mm-hmm. And how old was your husband when he was diagnosed, Maureen?
50.
Right. Yeah. And how about you, Simon?
So the day I was diagnosed, I got back to my car in the car park and just sat there and thought, wow, this is big news. And I hadn't taken in what the neurologist had said, so that was a very short conversation, and it doesn't really sink in properly. So I Googled Parkinson's and got the Parkinson's UK website, and then rang the helpline and had a great conversation with somebody who talked me off the ceiling for about an hour and gave me lots of information, answered my questions, and was massively supportive to me. That was what I needed at the time, just to get those answers to those first questions. And then I thought about going to groups, but to be honest, I was scared of seeing other people with Parkinson's and thinking about progression. So I avoided groups for quite a long time. I now go to my local group and find it very, very supportive, and also good to support other people. So we had a guy join the group a couple of months ago who'd just been diagnosed a few weeks earlier, and just to have that peer support was so good for him. To be part of that peer support group was very good for me as well. So I found the groups good for me now. But for the first probably 5 or 6 years, I did avoid them.
Yeah, thanks, Simon. That's really great to hear. And it's got to be at the time that it's right for you.
It has, very much so. It's all about being ready for it, and also you can go and stop, so you can dip in and dip out, and that's quite a good way to do it as well. Get support when you most need it.
Yeah, and we do have groups specifically for younger people as well. So just to mention that. And there was another question came in about somebody whose husband was diagnosed with Parkinson's recently, asking about how important it is around falls prevention and what sort of physical activity or gentle exercise could be done perhaps to help with risk of falls and just general disease progression. And if anybody wants to, maybe Camille.
Yeah, so as we've already discussed, falls is a big deal for anybody. If you fall as you get older, that can be very life-changing, and it's a particular risk in Parkinson's to have falls because the balance reflexes are affected, and people freeze. So some of the listeners might have experienced that, where the feet stick to the floor and you can't get going, and that happens more in crowded places or on turning or reaching, and then over people go. And of course, the big thing that we want to prevent is fractures, particularly hip fractures. But falling itself is a very frightening experience, and so we're very keen to prevent falls. So in terms of exercises, if you feel that your balance is getting a bit more dodgy and you feel that your risk of falls, or if you've had a fall, or you're experiencing something like freezing, which is associated with a higher risk of falls, and particularly, and I can see comments coming through in the chat where people feel they don't have easy access to services, because what you really need to access is physiotherapy. And a lot of physiotherapy services are community-based, and they will take referrals, allow for self-referrals. So it's worth exploring that on the service websites if you can. If you don't have access to a Parkinson's nurse or your Parkinson's service, and you are falling or you feel at risk of falling, then try and access physiotherapy. And the chances are that what they will provide you with is a set of exercises and guidance around maintaining your core muscle strength and balance. So putting the system, the core muscles and your postural reflexes through exercises to make sure that you're doing everything you can to maximize your balance and core muscle strength. That's slightly different from the benefits of exercise for slowing disease progression, which is a different sort of exercise. That's almost high intensity or longer duration of moderate intensity. That's really getting the heart rate up and to exercising to the point of breathlessness. And as a nation, we should all be doing whatever it is, 150 minutes a week of moderate intensity exercise. And over a certain age, also 30 minutes a week of weight-bearing exercise, because that also keeps our bones strong. And I'm sure I'm one of many people that don't exercise as much as we ought. Exercising is important in Parkinson's for all the reasons we've talked about. Maintains bone strength, muscle strength, maintaining your cardiovascular fitness in the face of a condition which unfortunately is going to get worse with time is really important. And on top of that, there's the mental health benefits of exercise and particularly getting out in the fresh air. And this isn't just for Parkinson's, it's for all of us, and being part of an aging society. The benefits for exercising outside with aging are there, even without also living with Parkinson's. On top of that, there is some evidence, increasingly strong, but early signals that exercises benefit for treating the symptoms of Parkinson's. That's pretty robust. So after a bout of exercise, often people feel their symptoms are better, and that can be maintained for quite a few hours. And there is also increasing evidence that exercise might be protective for Parkinson's, that it might slow Parkinson's progression, but this is the more intense, high intensity or moderate intensity exercise. So maintaining cardiovascular fitness and the ability to exercise at that level, I think, is really important. And if I may, Linny, just sneak in a comment to other questions that came into the Q&A about delaying medication. And particularly, there was somebody who asked being younger onset, so I think it was for age 41 or 42, and maybe just a bit of left-sided stiffness. That was the question. My answer would be, if you are feeling that your symptoms are impacting on what you want to do in your life, then really think seriously about taking some levodopa, because it will make those symptoms, touch wood, go away. And when you're thinking about what you want to do in your life, be aspirational for yourself, particularly if you have got your onset Parkinson's, because you're going to be living with your Parkinson's for several decades. You know, life expectancy at 40 is much longer than life expectancy at 80. So hopefully you're going to have many decades with your Parkinson's, and you want to keep as fit and as healthy and as active, physically, mentally, socially active as much as you can. And with the best will in the world, a condition like Parkinson's will constrict your world. You'll start going out less, you'll meet people less, you might have problems with your confidence if you're slow in moving or eating, or you've got a tremor that you might be embarrassed about. So think critically for yourself. How much is Parkinson's constricting your life and your activities? Think back, what were you like 5 years ago, 10 years ago? And the medication might help you get back to that. And that, in my mind, would be a reason to start earlier rather than later. Accepting that you might not need that immediate symptomatic benefit, but it might be that your life is already constricted in really subtle ways that you hadn't really appreciated.
Did you have any hesitation like that, Simon? Because you were diagnosed quite young.
Yeah, so with medication, I thought about taking it sooner. It was really, to be honest, now I wish I had taken more medication sooner. I do a lot of exercise now, so I used to do a lot of swimming. I now do a lot of running, so trying to change my exercise routine to get more exercise. And as per what was just said, I get a lot of immediate benefit from the intensive exercise, more so from running than just walking. So I've tried to build more exercise into my daily routine wherever I can do. But being someone who's working full time as well, it's quite hard to fit it all in. So when you think about all the things you have to try and think about, so medication, meal times, exercise times, it takes a lot of planning.
Perfect, thank you. And Maureen, your husband is still physically active and fit, and Parkinson's hasn't held him back?
No, except to say when he fell and broke his ankle, but that was non-Parkinson's related, that fall. That actually happened in the gym. But no, he has kept the exercise going, and is even more determined. And can I just say, he's actually the first person with Parkinson's now to be a para-athlete. He went through that process with the broken ankle and is very much now trying to raise the profile of Parkinson's in athletics.
Wow, amazing. Fantastic. Congratulations to him.
Yeah, that's brilliant. Lynnie, can I just very quickly wave a flag for our, believe it or not, Parkinson's UK has a YouTube channel, and we've got all manner of exercises, from seated exercise, because not everybody obviously can get up and sort of be that mobile. So we've got things from seated exercise right through to a selection of high intensity exercises. So it doesn't have to be in the gym. If you're the sort of person that wants to do things at home, our YouTube channel has got, it must have about a dozen, I think. So well worth a look. It's all free, obviously. Thank you.
Yeah, brilliant. Good plug there. And there's quite a specific question in the Q&A about sort of physical activity, exercise and postural drop. Any comment on posture and exercise, maybe, Camille?
Yeah, that's an excellent question. So a postural drop is a drop in blood pressure that happens when people go from lying to standing or sitting to standing. And ordinarily, when we go from lying to standing, we're able to maintain our blood pressure because our blood pressure reflexes kick in and our blood vessels constrict, and that keeps the pressure in the system and blood going to our brains. And we'll all have experienced it. If you get up too quickly on a very hot day, the blood vessels are all dilated. We stand up, blood goes into our boots, and we feel like we're going to pass out or fall over. In Parkinson's, those blood pressure reflexes are sluggish. They're not as robust as they used to be. And so often people can stand and the blood pressure falls and it doesn't go back up in the way it should. So not enough blood gets to the brain. People feel lightheaded and can sometimes fall over or lose consciousness, even if it's very severe. There are other situations that can cause a drop in blood pressure. So if blood is diverted elsewhere, so for example, digesting food. So often people might feel lightheaded after a heavy meal. And sometimes exercise, of course, means blood needs to go to the muscles. And so people can feel lightheaded after exercise. Excuse me, in those situations, what I would advise is there are treatments for treating blood pressure drops to help maintain the circulating volume or to help support those blood pressure reflexes. But keeping well hydrated is really, really important. So everyone should be, unless there's a reason not to, drinking at least 1.5 litres of water a day, probably closer to 2, and really help your circulation and your blood pressure to be maintained. And if you think that you're going to have a drop in a particular scenario, so say after a meal or after exercise, then drinking 300 mils, 300 to 500 mils of cold water, and you might keep this in a flask with a few ice cubes in it, not freezing cold, but sort of good tap water cold water will put your blood pressure up and help prevent a drop. And you can help prevent a drop also by other things, such as wearing full-length TED stockings, putting a bit of a tilt up on your bed at night. However, the other side to this question, and this might have been what Pauline was asking about, was whether exercise is helpful in preventing postural drops. That is also the case. So if you're in hospital, for example, or a prolonged period of bed rest, by prolonged I mean, you know, a day or two or more, if you've got sluggish blood pressure reflexes, they're going to become even more sluggish. And the longer that you are chair-bound or bed-bound, the worse that's going to be. You really need to be exercising your blood pressure reflexes, which of course will come with exercise. So keeping active will help prevent future blood pressure drops and help your blood pressure system remain as functional as it can be. And so exercise is certainly something that we would be advocating for people who do get blood pressure drops. So I hope that has answered the query that Pauline had there.
Great, thank you. And then I wanted to come to Alison's comment and question about, she says, what are people's views on when to let close family members know about the diagnosis? Don't know, Maureen, Simon, start with you.
I'll chip in if you like. So I told my partner straight away, didn't tell my kids for about 2 years because my son was going to GCSEs and I didn't want to sort of cause a distraction in his life. So I held off on telling my kids. With hindsight, I probably should have told them sooner because it gives them more time to use the situation before things develop. But my logic at the time was kids going through exams, didn't need the extra stress and burden, so didn't tell the kids. I told my parents after about a year, once I got my own head around the diagnosis. So I sort of staggered my involvement of my family. But if I had my time again, I'd probably be more open earlier and share things sooner.
Did you have any sort of support with that or anything, or did you just kind of deal with it yourself? Did you talk to any health professionals about it first or anything like that?
I talked to my Parkinson's nurse about how to tell my kids, and she was very helpful. So she gave me some advice and guidance on what to say, what not to say, and also likely questions. When I actually told the kids, there were very few questions anyway, so they more sort of said, "Got it, Dad," and then the questions come later down the line once they processed it.
Yeah, interesting. Maureen, how was it for you?
Right away. We got the diagnosis in November. We decided not to tell the kids until after Christmas. But when we told them, they said, "Oh, we knew." Because my daughter had, well, do you know what? Sometimes the symptoms are very hard. You know, if somebody's got a tremor, and in this day and age with the internet, my daughter said to me, "I knew, Mummy, I Googled it." So yeah, we've been very open from the start, and for us, that was what worked because there was a lot of support and friendship there. I think it's hard, you know, and I know somebody has mentioned about their father being in denial, and I think that puts extra pressure on you if you're not able to share or talk about it. So yeah, from us, we were very open from the start, and that was Patrick's choice. It was his condition. It was how he wanted to move forward with it. If he hadn't wanted to tell people, I wouldn't have told people. But no, he was very open and honest, and the support was there from the start.
Through friends and things like that were helpful.
Yes, some of them which we found were quite aghast. Their problem was they were getting dementia and Parkinson's mixed up. So when Patrick said he had Parkinson's, they were like, right. No poker face, and then they realized, I think too for us, because it was a bit of a relief to get a Parkinson's diagnosis, because we were kind of being led down the path of possibly motor neuron disease. So at that time, it was like, well, thank God it's not, it's Parkinson's. But no, very open from day one.
Anything from you on that, Sandy?
Yeah, we're aware of there's a website called parkinsons.me, and they've got some really good tips on telling children of all ages, including teenagers. I don't want to say suggested wording, but they've got some good things to tell you about. Or to guide when having these conversations. There's a section on telling your partner or your parents. So, and I think it's already been said that it's very individual. Some people will take a while to get their own head round a diagnosis of Parkinson's and will want to sit with it and not have to explain it to other people. That's something that has stayed with me. A lady told me this my first months on the helpline, I think. She said, I've had it for 6 months and I haven't told anybody anything yet. I'm getting to the point that I need to tell my employers soon so they can make reasonable adjustments, but I'm not ready. She said, it's my news to tell and I'm not ready to tell it yet. I think she worried about having to answer questions that she may not know the answers to herself, may not have felt emotionally ready to be asked questions of. So very individual thing.
Thanks, Sandy. And just anything from you, Kelly, about that sort of stuff?
I don't think there's any right or wrong answers, really, is there? I've got patients in clinic who have told nobody. I think for me, sometimes when I get a younger patient in who works full time, they've got quite a professional job, they're frightened to say anything to their work because they think they might be treated differently. So I think it's very individual. And yeah, I don't have any, should you tell your family, shouldn't tell your family. I think when you need the support should be there either way.
Yeah, thank you. And just a little plug for our helpline there for anybody who is working and has any concerns about talking to their employer, do come and talk to us about it, because you have rights at work and things like that, and they'll be happy to support you with that. I make it 2 minutes to 8, so we're kind of getting ready to draw to a close, really. I don't know if there's any real quick ones we can whiz through. I don't know if you've had a look, Camille, to see if there's anything that you might be able to answer around medication or anything. Did I see something? Yeah,
I saw a question about a DAT scan, but it might have been on the questions that were submitted before.
Yeah, so I think the question was, following a DAT scan and a diagnosis of Parkinson's, could that diagnosis be wrong?
So what a DAT scan looks at, this is that stands for dopamine axonal transport. So it's a dopamine transporter receptor. And what that is looking at is receptors that are on dopamine producing nerve cells. And in Parkinson's, because you lose dopamine producing nerve cells, the signal on that scan is reduced. So you have definitely got something going on in the brain, which means that you're losing dopamine producing cells. And it is most likely, because it's more common, that is Parkinson's disease, but the scan doesn't distinguish between Parkinson's disease and other diseases which cause loss of dopamine producing nerve cells. So yes, there is a chance that the diagnosis could be wrong, or might change, I should say, because all of these diagnoses are clinical, so as opposed to a single diagnostic test. So often they do evolve with time, and that brings me back to where we started the conversation, which is how often should people be seen? And part of the reason for being seen regularly through the early few years of having Parkinson's is to identify if there is something else that might be causing your symptoms, or if you have had a DAT scan that might be causing loss of dopamine cells, that isn't Parkinson's, because other things will occur over the first few years that will make that more obvious.
Oh, sorry, just unmuting there. Great, thank you. So we've more or less come to the end. Martha, did you say you've got some slides to share just before we say goodbye? Thank you. Yep, so just a big plug for our helpline. If you want to talk things through, or you just need somebody on your side, our helpline is there to support you. The opening hours are on our website, and you'll get to speak to somebody like Sandy. There's the Parkinson's On app if anybody wants to pursue that and have a look at it, about timings, and the Parkinson's Me that Sandy's just mentioned there. And then I think for me, it's just to say thank you for your time. Thank you for coming. Thank you so much to all of the panelists for answering all of those questions. We will send the recording out and share it with you, and we'll ask you for feedback. And if you'd like to see perhaps other webinars on other topics or themes, we'd love to hear about that too. And don't forget, we're there, and nobody needs to face Parkinson's alone. Thank you.